Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American-owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi, my name is Mike Sullivan. I'm one of the instructors at Valor Medical Services. This module is Pediatric Medical Module A. We're actually going to be developing several pediatric medical modules. This is going to be the first one, and we'll be covering two topics in here as we go on through. Now, our course objectives through this are going to be identify some common pediatric medical emergencies and their causes or etiologies. We'll identify anatomical and physiological differences between adults and pediatric patients that play a role in these. We'll compare various common pediatric respiratory emergencies and compare the different stages of shock in pediatric patients. We'll also define various categories of pediatric shock and some of the management therein. Now, when we talk about pediatric respiratory patients, there's a few key differences we need to start off with at baseline. We know that pediatric patients overall are particularly susceptible to respiratory illnesses and issues. Pediatric patients have less physiologic stores and higher metabolic demands for oxygen, so therefore they're more susceptible to hypoxia. Simply stated, they don't tolerate low oxygen intake as well, therefore they're going to become hypoxic more quickly as their demand is higher. We also know that pediatric patients may have less developed immune systems and thus be more susceptible to various infectious diseases that an adult or someone similar may fight off. We also, going forward, pediatric respiratory issues are due to some other differences. Infants are typically nose breathers. Congestion or swelling can easily occlude their nares. We know that the tongue is proportionally larger in relation to the mouth, leading to an increased risk of potential airway occlusion. The airway is smaller and much narrower, also less rigid, so therefore congestion and swelling can easily lead to occlusion of the upper airway. The chest wall of a pediatric patient is weaker and more pliable than that of an adult, and thus will wear out faster under duress or increased work of breathing. Their muscle groups through the intercostals are going to be smaller and therefore tire more quickly. Children have smaller lungs, thus fewer alveoli. This way, obstruction can occur more easily in cases of infection. It takes much less mucus and pneumonia or infection in their lungs to occlude a large portion of their lungs. We also know that smaller children have higher oxygen demands than adults, and therefore, again, hypoxemia can come on rather quickly. Now, our overall approach as EMS providers to pediatric patients. When assessing a pediatric patient with a respiratory complaint, providers should be evaluating the following: their respiratory effort or their work of breathing. How hard are they working to actually move air in and out? We should listen for abnormal respiratory sounds. As we know, normal breathing should be quiet and should be effortless. We shouldn't be hearing a bunch of strange sounds. Respiratory rate. Is it higher than normal because they're working harder to fight hypoxia? Is it lower than normal because they're becoming tired? We can look at the severity of the issue. Are they in respiratory distress or are they in respiratory failure? And we should know the differential between the two. Respiratory distress is when they're struggling to meet the body's metabolic needs, but they're still meeting the needs. When we get to respiratory failure, we're talking about a child who is no longer meeting the body's metabolic needs. We may see signs of altered mentation. We may see signs of decreased responsiveness, may see cyanosis, may see shunting. All of these would indicate us that the child is beginning to go into failure, which is a very ominous sign. If not corrected quickly, we may lead to respiratory arrest. Now, some of the sources of respiratory issues, we group them into three groups here. Upper airway problems. It could be a choking or foreign body airway obstruction. Could be an allergic reaction. Could be some type of trauma, either to the mouth or the upper airway, damage in there. Could be croup or epiglottitis. We can have lower airway issues, such as asthma, bronchiolitis, pneumonia, or pulmonary edema. And we can have loss of ventilatory control due to one of either overdose, could be an injury, or actually a stroke. Now, when we look at the upper airway, choking is one of the most common causes of sudden onset respiratory distress in an afebrile patient. Typically, this can be managed with core BLS maneuvers and may be cleared by a parent or caregiver prior to our arrival. We always need to keep in mind, if we get called to a sudden onset respiratory distress, the child hasn't been sick, there's been nothing going on, they were fine just a moment ago, especially in the younger age groups, what could they have possibly put in their mouth? So choking would be a very common call we would get. We can have an allergic reaction or anaphylaxis, and may be a result of a known exposure or an unknown exposure to an allergen. A child may not know that they're allergic to something. A parent may not know they're allergic to something. It could be the first time they've ever had a reaction to this item, whatever it may be. And think about it could be an unknown exposure, especially with a very little child. They may have gotten stung by something or bitten by something, and if we don't see the sting or the bite mark immediately, we may not know what's causing the rash. If we look at the child for a rash, swelling, or hives, all of this would lead us to believe this is some type of allergic reaction. Trauma, of course. Any type of trauma or injury to the face or neck can lead to airway compromise. If we think about a child who may fall up against the table in a coffee table in a living room or something else and land right on their neck, they may fall and have something hit them in the throat, or they may just have been hit by something accidentally. Now, when we get into croup's a little bit different bird. Croup may be very mild at first, but will progress rather quickly. Initially, it will present with a runny nose, cough, sore throat, may not seem like much of anything. As it progresses, the child will exhibit a harsh, barking, seal-like cough with stridor at rest. Eventually, respiratory distress and respiratory failure. The harsh barking cough is one of the telltale signs of croup. It's a very sharp cough that will be pretty much your best indicator. It's normally caused by a virus and occurs most commonly in children under 6. Management is initially focused on maintaining an airway and avoiding upsetting the child. Now, this child may need IV steroids, such as anti-inflammatories, or nebulized racemic epinephrine. Either of these will again help to open up the upper airway some and try to deal with some of the swelling, some of the inflammation, and try to open up and provide better air exchange. Now, epiglottitis. This is an acute infection of the upper airway that may progress quickly to a complete airway obstruction. Typically, again, the patients are under about 7, and the diagnosis is typically based on 3 Ds. The patient is drooling, dysphagic, and in distress. The child may present with a sore throat, they may have a muffled voice, may show significant distress. Stridor is always a late sign of epiglottitis and may indicate imminent respiratory failure. Now, when we deal with these children, they are extremely high risk. If their epiglottis swells shut, they may well go into respiratory arrest, may require immediate surgical cricothyrotomy, and if you can't do that, you could have a problem. Ideally, we do as little as possible when you're dealing with possible epiglottitis. Now look back at that: drooling, dysphagia, and distress. If you have a child 7 or less, presents with respiratory distress and drooling, can't swallow, and may have a sore throat or muffled voice, do as little as possible. Avoid agitating or upsetting the child. Do basic blow-by if the child will allow you, and get to the hospital as quickly as possible. Now, as we move down the airway a little bit, a lower airway obstruction is common asthma. Now, this is a reactive airway disease or inflammation of the bronchial smooth tissue of the lower airways. It may be chronic or it may be acutely exacerbated by an infection or exposure to some type of allergen or chemical. The cardinal presentation will be expiratory phase wheezing. Basically, the patient wheezes when they're trying to get air out. However, if the patient is not moving enough air, they may not produce wheezing. If the airway is clamped down too far, we may not be able to move enough air. This may also result in what we call air trapping, where air gets trapped in the child's lungs. They can't exhale adequately, so therefore if they can't exhale, they're unable to inhale fresh air. Now, this may tire a child out very quickly and may lead to respiratory failure very quickly. Now, many times the treatment will be nebulized bronchodilator. However, other routes may be indicated if the condition persists. Especially if the child's not moving enough air, a nebulizer may not be able to actually get the medication to the inflammation of the bronchial smooth muscle, so we may need to go with some other type of treatment via an IM route or something similar to that. Another lower airway issue we'll see is bronchiolitis or bronchitis. This is a viral infection of the lower airways. Patients may present with a low-grade fever, runny nose, or irritability. In some cases, this may progress to a productive cough and thick respiratory secretions. Now, these thick secretions, as we mentioned before, can really block a thin, small airway very quickly and cause a great deal of distress trying to get air in and out. Another issue we see is pneumonia. Now, pneumonia can be an infection or an inflammation of the lower airways, can be caused by virus, bacteria, parasite, or fungus, and it may rapidly progress to SIRS, sepsis, or shock. Pneumonia will typically present with a fever, shortness of breath, hypoxia, cough, and decreased or congested breath sounds, and possibly abdominal pain. Our care for pneumonia is typically centered on oxygenation and hydration to try to help the body fight the infection. Remember, any patient who's starting to border into SIRS or sepsis, we need to make sure we're adequately hydrating them. Pulmonary edema is our final lower airway issue. Now, pulmonary edema can be resulting from a cardiac insufficiency issue or other sources. This patient will present with crackles or moist cough, poor tidal volume, and possibly tachypnea. This can also result from a chemical inhalation or overfluid administration and some types of overdoses. One key differential between this and pneumonia is that isolated pulmonary edema patients are typically not febrile. So if we're trying to make our differential, there's something in the breath sounds we're not sure. Well, if they're febrile, we want to think more pneumonia. If they're afebrile, we say, well, this could more likely be pulmonary edema, and use that to guide our treatment. Now, as we look at disordered ventilatory control, all of these causes typically involve some other body system that's experiencing a failure or problem and thus causes a problem with the patient's ability to control their ventilatory or respiratory effort. One of the most common, unfortunately, is overdoses. Many medications or classes of medication can cause decreased ventilatory effort. These can include opiates, benzodiazepines, muscle relaxants. Typically, this is managed by providers securing the airway either with an OPA or an NPA and assisting the child with the ventilatory rate and depth. In some cases, typically opiates, we may have a way to reverse the effects of the medication, but barring this, we'll take over their respirations and we will provide respiratory effort for them manually with a bag valve mask. Now, when we're looking at our differential between opiates and benzodiazepines, typically opiates will result in pinpoint pupils. So if, again, decreased respiratory effort associated with pinpoint pupils, we want to think more opiates. However, if the pupils are very dilated, it's more likely a benzodiazepine or a muscle relaxant. However, if we do suspect an opiate, we can go ahead and administer Narcan or naloxone, and that can possibly override or blockade the opiate effect and assist the child in regaining their own respirations. If that doesn't work, again, core BLS maneuvers, bag valve mask with an OPA or NPA will still provide us coverage and help the child breathe until they can work through whatever the issue is. Another failure of respiratory control can be an injury. Any injury to the central nervous system, whether it's the upper section of the spinal cord or the brain, may result in the patient being unable to control their own respiratory effort or volume. The medulla coordinates pulse and respiratory rate. These impulses are then sent to the relevant muscle groups or the relevant area of the body via the spinal cord. In cases of damage to the spinal cord, the level of the injury will determine not only what muscle groups are affected, but also whether or not the signals get there at all. Now, if a child is suffering from an injury that we suspect either a spinal injury or a head injury, causing them to lose ventilatory control, again, the simplest, quickest way to fix this is with a bag valve mask and an oral or nasal airway. We can take over and provide adequate depth and rate while we determine what else we can do to override this problem. The last listing in the disordered respiratory control would be a stroke or a tumor. Now, much like physical trauma, damage done to the central nervous system via a stroke, tumor, or growth can cause a loss of respiratory effort or drive. This can be due to signals not being sent or signals being blocked on the way to the muscle group. The only difference between this and trauma is the cause of it. This would be an internal cause, however the trauma would be an external cause that we may be more aware of. In either case, we need to maintain the child's respiratory rate and depth for them while we determine the cause. Now, let's move on into shock. Shock, at simple definition, is defined as the body's failure to provide adequate oxygenation and nutrient to all the body's cells. This failure can lead to the body shifting from aerobic, which is our normal metabolism, to anaerobic metabolism. Now, anaerobic metabolism will be far less efficient at energy production and results in more byproducts or waste products from the process. So ideally, we want to make sure we switch back to aerobic as quickly as possible. Now, we know that pediatric shock patients are going to have less physiologic stores and higher metabolic demands. Therefore, again, they're more susceptible to hypovolemia or hypoglycemia. They go through fuel and oxygen more readily, therefore they need a more ready supply. Pediatric patients may experience more rapid rises in fever or body temperature and can be more susceptible to environmental extremes. Therefore, if it's particularly cold outside, they may burn more fuel than a comparable adult would, thus working towards hypoglycemia more quickly. Now, barring some type of congenital or birth-related issue, most pediatric patients, fortunately, don't have significant cardiac problems. Adults are more likely to have a cardiac-related issue causing some type of shock, whereas children are usually just not members of the Sick Heart Club. So, although pediatric patients may have a larger circulating blood volume in proportion, they have far less actual blood than adults. Early signs of shock can be detected with 15 to 20% of blood or fluid loss. Now, if we look at children having a circulating blood volume of roughly 70 mLs per kg, infants it's about 70 to 75, and a 2-year-old about 250 mLs of blood is about 30%. So now when we figure 250 mLs of blood would be 30%, that doesn't take a great amount for a child to be in shock and start showing signs of shock very quickly. Now, the first phase of shock is compensated shock. Now, in compensated shock, the body senses the metabolic deficit and takes steps to overcome the issue. It's going to increase the heart rate. It's going to increase the contractile force of the heart. It may constrict the peripheral vasculature and start trying to shunt the core. This means that the body is going to make sure that the liver, heart, brain gets perfused, even if it has to shunt away from the pinky toe. Now, we'll also have an increased respiratory rate, and the body is going to route the blood to make sure it's supplying vital organs. In the presentation for compensated shock, typically anxiety or restlessness. May see mild confusion starting. They'll typically have a normal BP, but a narrowing pulse pressure. So while your systolic is normal, your diastolic may actually increase from the clamping down or the squeezing of the peripheral vasculature. We may have strong central pulses, but we may notice weakening peripheral pulses, again as the body shunts. Mucous membranes may become pale, and we may see decreasing urine output. Now, while we may not notice urine output initially as an emergency response, this is something we can always ask the parent as far as how many diaper changes they've had in the last several hours, and then compare that. Is this normal or is this abnormal? If the parent tells you that, oh no, this is very abnormal, this is much less diaper changing than usual, that would indicate to us the child's not producing as much urine. Therefore, that would be another checkbox, and we could say, yes, we're indicating compensated shock. Now, unfortunately, if not treated, compensated shock will move to decompensated shock. Now, decompensated shock in some texts is also referred to as hypotensive shock, whereas compensated could be referred to as normotensive shock. Regardless of the phrase we use, decompensated shock is where the body's compensatory mechanisms begin to become overwhelmed and start to fail. Now, presentation for decompensated shock will include potentially agitation. They may become lethargic after a while. We'll see drops in systolic BP, weak central and thready peripheral pulses if they're present at all. The increased respiratory rate, but it may begin to fall later as the child tires. Delayed capillary refill may be over 3 to 5 seconds. Pale mucous membranes and mottled skin, potentially cool and clammy extremities. These are all very ominous signs as they let us know that we're definitely behind the curve and we need to fix the problem as quickly as possible. Now, let's look at some of the different types of shock. The first one we'll discuss is hypovolemic. This is due to increased or decreased volume of circulating blood. It may result from blood loss itself, fluid loss, electrolyte losses, or even some sort of endocrine disease. The next one will be distributive. This is based on poor vascular tone or peripheral vasodilation. The distribution system has gone bad. Although the child won't have lost any actual blood volume, it may result in relative hypovolemia because the container has become so much bigger that it's now not as full as it was. This can typically occur from SIRS, septic shock, allergic reaction, or some type of neurological function or injury. If we think about a spinal cord injury patient, below the level of the injury, the neurologic system can no longer maintain vascular tone. Thus, those vessels will dilate, pooling will occur, and again, even though they may not have lost a considerable amount of blood, they may go from full to 2/3 full or half full very rapidly. We can have obstructive shock. Typically something in this is obstructing the blood flow. It may obstruct the blood flow that's leaving the heart, or it may obstruct blood flow returning to the heart. This can result from a tension pneumothorax, which increases pressure within the thoracic cavity. It may result from a pulmonary embolism, blocking blood flow to the lungs or within the lungs. It may result from cardiac tamponade, not allowing the heart to expand adequately, thus not filling and not preloading the heart adequately. We can have cardiogenic shock. Now this occurs due to some type of failure of the pumping system. The obstruction to the filling of the heart could be poor preload. It may result from a conduction abnormality or arrhythmia. It may be a rate-related issue, from hypoxia, the heart muscles not getting enough oxygen, or a toxicological problem. Think about a patient who may have accidentally become poisoned by getting into grandmother's heart medicine. This could definitely cause the pump to fail and thus not adequately perfuse the system. Now, the first step towards managing any of these shocks is to try to determine the causes. If it's a pump failure, it's a heart issue. Fix the rate or the contractility problem. If it's a pipes problem with the vasculature, treat the cause of the condition. Do we know why the vasculature is doing this? We may need to even use vasopressors to help try to clamp down the peripheral vasculature and get the blood pressure up. Is it a fluid problem? From either blood loss to fluid loss. Replace the lost fluid or blood to replenish the volume. In these cases especially is where we'll give very aggressive fluid boluses up to 20 mLs per kg, and that way we can do that as long as we've got good breath sounds, trying to get the fluid level up within the body to make sure they have enough circulating blood volume. In closing, although pediatric patients have excellent compensatory mechanisms, when they fail they will deteriorate quickly and fail dramatically. Pediatric patients can tire very quickly, and in many cases, it's a key for providers to determine the cause in order to treat it effectively before they tucker out. A key aspect to managing a pediatric shock patient is identifying the cause and type of shock to treat it early before it gets into that decompensated or later stage. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.